Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture series, we're going to go through reproductive health pharmacology for both male and female systems. So let's go ahead and start with female reproductive medication, and we'll start with oral contraceptives. Oral contraceptives is a large class of drugs taken by millions and millions in order to prevent pregnancy as well as for other indications. I'm going to start with some basic terminology. You're going to see the term OCP, and that refers to oral contraceptives. Oral contraceptives would include both progesterone-only medications, such as the mini pill, as well as the traditional combination estrogen progesterone contraceptive. You may also see this referred to as COCs, combination oral contraceptives, and this would be a subclass of OCPs, and this would be specifically the birth control medications, the pills that contain both estrogen and progesterone. So we're going to call this the combination oral contraceptives, the COCs. That's the most appropriate manner, but you may commonly see the term OCP. The drugs in this class include northindrone with ethinyl estradiol, norgestamine with ethinyl estradiol, as well as some others. There are at least 50 different brand names by which birth control goes by, so I'm obviously not going to list all of them. How do these work? These prevent ovulation by suppressing LH, luteinizing hormone. These are also called hormonal contraceptives. Now, what do we use this for? Obviously, most people use this for contraceptive. It's also used to treat acne, as well as to reduce the risk of endometrial and ovarian cancer. Off-label, it's used for dysmenorrhea, meaning people who want to regulate their periods. It's used for menstrual suppression, people who don't want to have bleeding, as well as PCOS symptoms. The adverse effects of this include blood clots and hypertension. I want to clarify the blood clot point, because you're going to see this throughout the reproductive health lecture, and you're going to see this in a bunch of other places in pharmacology. Anytime you see that a medication can cause a patient to have blood clots, you need to first of all understand that this medication would be very high risk to give to someone who's a smoker, someone who has a previous history of blood clots, or has other risk factors for a blood clot like atrial fibrillation. Also, if a patient has a medication that has a risk for blood clots, you need to be assessing them for blood clots. So you need to be assessing for signs and symptoms of a DVT or a PE or an MI or a CVA. So all of those are different considerations to have. Next, I want to explain what is withdrawal bleeding. Obviously, we should be familiar with what is a period where a woman goes through her menstrual cycle. However, withdrawal bleeding is what we talk about in pharmacology when we talk about oral contraceptives. When a female is taking an oral contraceptive pill, when she stops taking it and she starts to get what we call a period, it's actually technically called withdrawal bleeding. What is withdrawal bleeding? It's when the hormone levels drop as a result of stopping the medications and the woman sheds her lining. That is what a withdrawal bleeding is, and we do use it very carefully in pharmacology terms. We don't usually use the word period because we want to be clear that this is withdrawal bleeding that we technically induce by stopping the medication, by withdrawing the medication. Oral contraceptives have a black box warning that they have that increased risk of blood clots that I mentioned, especially if the patient is a previous smoker, especially if they are over the age of 35 and a few other risk factors like I mentioned. Next, the traditional oral contraceptive pill is most commonly taken in a 21 7-day cycle. What does that mean? That you take 21 pills and then you have withdrawal bleeding for 7 days. During those 7 days, you take a placebo pill. The placebo pill sometimes contains iron. Obviously, iron would be related to the fact that the woman's bleeding, so we want to fortify them with iron so that they don't become anemic. And as well as even the ones that don't contain iron, we recommend that they keep taking the pill in order to get into the habit of every single morning to take a pill. Generally, before we get to that, we do have other options available in addition to the 21 and 7, which is the most common. There's the 24 and 4, where they take a pill for 24 days and then a placebo for 4 days, in which case they would have 4 days of withdrawal bleeding. That is just as equally recommended, and it is becoming more popular. We do also have the 91-day cycles where they take 84 pills and then they have the 7 days of withdrawal bleeding with the placebo pill. That's also becoming more common, and in that case, the woman would get 4 periods per year. There is no, at least not to my knowledge, and all the data I reviewed for this video, there is no harm in doing that. There's no reason a woman must go through a menstrual cycle each time. There's no harm, to my understanding, in taking only having 4 periods a year versus the traditional 12 periods a year. There is also one medication, it's called Amethyst is the brand name, that offers you a 365-day pill. So you take a pill, an active pill every single day, and then in theory, you would never get a period. There is some higher risk in that case of what's called breakthrough bleeding, where a woman is taking her medication and she's taking an active form of the pill, not the placebo pill, and when you're taking for 365 days, you may still get some spotting, which is called breakthrough bleeding, and that is a higher risk when you start to take the 365-day pill. Next, we have really important education point that a bunch of medications interfere with oral contraceptives. Two huge classes to know. One is antibiotics, one is anti-epileptic. So if a patient is taking an antibiotic, unless you know specifically that it doesn't interact with their oral contraceptive, you should recommend to the patient that until they get their next period, they should continue to use some other form of contraceptive, such as condoms, as an extra method of being cautious. Again, because antibiotics and antiepileptics are known to reduce the efficacy of this medication. How much, I can't tell you. Next, in terms of the antiepileptics, a lot of patients will be on anti-seizure medications like Depakote or something like that. And these medications can also lower the efficacy of their oral contraceptive. So again, either oral contraceptive wouldn't be the best option for them, or they may want to at least understand the risk that this may not be as effective as it would be in the general population. Birth control, the traditional combination oral contraceptive, is considered the number one most effective method of birth control. It is 99.9% effective at preventing pregnancy. Next, let's go through some patient teaching points for you to educate your patient when starting this. First of all, this should be started at least 5 days from the onset of bleeding. Obviously, the exception there would be the 28, 4, and 4-day pill, which will be started exactly 5 days later. We generally recommend to patients start a new pack on a Sunday, so that just keeps life simpler. A alternative method of contraceptive should be used for the first 7 days. That's what your book said. Or that's what some textbooks say. I have seen other textbooks that say that you should use it until your first period. A missed pill, if a woman forgets to take her oral contraceptive pill, if she forgets on Monday, she should take 2 pills on Tuesday. If she forgets Monday and Tuesday, then on Wednesday, then she should double up for 2 days to take both of the missed pills. But she should also know that this might not be very effective, so she should use oral or other methods of contraception until her next period. If 3 or more pills are missed, just stop and wait till you get your period, and then start over with a new cycle again. Obviously, if a woman does become pregnant, she should immediately stop taking her contraceptive. Next, we have a class of drugs. It's called the POP, the progesterone-only pill, also known as the mini pill, also known as an oral contraceptive. This is still considered an oral contraceptive. The drug over here is northindrone, which is the mini pill, and this works in a few different ways. This works by suppressing the luteinizing hormone surge. It interferes with sperm and egg movement, and it thins out the endometrium, making the environment less hospitable for pregnancy. What do we use this for? Obviously for contraceptive. This is considered less effective than the combination traditional ethanol estradiol with progesterone combination pill. This must be taken at the exact same time every day, or else the efficacy really goes down. The big benefit to this one is that two of them really. The two big benefits, I should say. One is that this can be taken right after childbirth. It is safe to take it during breastfeeding, as opposed to the traditional COCs, the combination ones cannot be taken during breastfeeding. Second big advantage is that this one does not have the risk of clots. It's the estrogen part of the pill that has the risk of clots. So this one does not have the risk of clots. This one, as of I believe 2021 or 2022, is available over the counter in the United States. I'm sorry, I may have that wrong. It might be more recent, but it is available over the counter in the United States. And the whole reason is because it doesn't have that risk of the blood clots. Next, we have a subclass of the progesterone only, and this is not a pill, this is a shot. This is medroxyprogesterone, also known as Depo-Provera. Depo-Provera is commonly given as an IM injection or subcutaneous injection. It is also available PO as an ingredient in progesterone-only pills. This one is used for contraceptive, for abnormal uterine bleeding, and for endometrial issues. It does have a black box warning that it can cause cardiac disorders, dementia, and breast cancer. It is not recommended to be used for more than 24 months, 2 years of contraception. We should switch to another method if we're going to keep doing it for longer than that. And using it by injection, which is the way it's commonly given, increases the risk of bone density loss. Again, I don't know how much you're familiar with from back when we talk in anatomy and physiology about the role of estrogen and bone density loss, but this would carry a risk of decreasing your bone density. Next, we have emergency contraceptives. This would be levonorgestrel or ulipristal. This is available over the counter, and this works by interfering with ovulation. This is considered an emergency contraceptive where a patient had unprotected sex and doesn't want to become pregnant. The side effect or adverse effect of this is abnormal vaginal bleeding, usually not very serious, just that they may get some spotting, something like that. This is only effective if it's taken within 3 to 5 days. Now, I covered myself by saying 3 to 5 days because the nursing textbooks I reviewed, some of the books say 3 days, some of them say up to 5 days. It'll still work. Everyone agrees after 5 days, it's no longer going to be effective. This medication or both of these, I should say, are very much less effective in a patient that has a high BMI. That doesn't mean we can double up on the medication. Definitely not. It just means they could still take it, and they should still take it if they're interested in the desired effect of contraception, but they need to understand that it's not going to have that 90-something% efficacy rate that it would normally have in a patient that has a lower BMI. Taking emergency contraceptive will not cause an abortion. It doesn't abort a fetus. It is certainly teratogenic and harmful and shouldn't be taken, but it will not abort a pregnancy. And this medication is available over the counter. It does not require prescription. Next, we have if a person does want to have an abortion, which is called medical termination of a pregnancy. In the US, this is done with two drugs. One of them is mifepristone, which is RU486, and the other one is misoprostol. Almost always they're given in combination. They take those two medications, and we're not going to go further into it than that. There is one additional medication that we do talk about in other lectures. It's called methotrexate. Methotrexate is a folic acid inhibitor. I'm sure most of you are familiar with the fact that folic acid is necessary for a healthy pregnancy, and this inhibits folic acid, thereby inducing an abortion. We don't traditionally use this as the standard abortion pill. We do use this for ectopic pregnancies if we need to abort it and in some other specific situations, but if you do ever see that on an exam or something, methotrexate can also be used to induce abortions. Next, we have some general pharmacology information related to pregnancy. I'll go into it a little bit. We do recommend to all patients to take iron and folic acid supplements, and we recommend this. Generally, we recommend this 30 days prior to conception. So if they're planning to start having sex unprotected in order to conceive, we recommend 30 days before that, the woman should already start taking iron and folic acid supplements. Generally, there's 100 different options out there from Walgreens, Walmart, any of those that have the one daily pill that has everything that you need in it. Next, if a patient does develop hyperemesis gravidarum, which is more commonly known as morning sickness, the first line medication for that is pyridoxine and or doxylamine. Both of these are available over the counter, and a patient can take either one or the two together. Actually, it comes two together in a prescription form in the same pill as a medication for nausea in pregnancy. Other options would then become metoclopramide or promethazine. You'll notice ondansetron is not on this list, which is Zofran. Zofran is a little controversial right now, and I'm filming this at the end of 2024. Zofran is a little controversial on whether or not it's safe in pregnancy. A large number of OBs do still recommend it, but plenty of them don't, so I'm staying out of it. Next, we have our first line medication for heartburn in pregnancy is going to be to take an antacid. They should avoid the magnesium or sodium bicarb antacids because those can cause issues with pregnancy. Finally, first line treatment for constipation in pregnancy is going to be non-pharm interventions such as increasing fiber, fluid, and activity. If they are going to take a pharmacological treatment, they should take one of the bulk forming laxatives, which is fiber such as psyllium or methylcellulose, or they could take docusate sodium, which is a stool softener. If a patient's going to be taking an over-the-counter pain reliever, an analgesic medication, or a fever medication during pregnancy, acetaminophen is the universally most recommended, certainly more than NSAIDs. And finally, if a patient's going to have preeclampsia, which is hypertension in pregnancy, the medications that we're going to use for this patient are going to be methyldopa, hydralazine, and the beta blockers. Those are going to be our first-line drugs in most cases to treat hypertension in pregnancy. So far we talked about preventing pregnancy, and then we talked a little bit about what happens when someone becomes pregnant. Let's talk about trying to become pregnant. So we have something called ovulation stimulant. Let me back up a second. Who's trying to become pregnant? Someone that has infertility. Infertility, in case you need to know this for your pharm test, is going to be diagnosed after 12 months of having sex at the time of expected ovulation without a resulting pregnancy. So that's infertility. And then we could treat that with ovulation stimulant. Now, I did say infertility is diagnosed at 12 months. Most OBs, at least that I'm aware of, they'll usually, if someone's really wanting and trying, and it's been, let's say, 6 or more months and no success in conceiving, they would be open to starting this even before you officially hit the diagnosis. The drug that we're talking about here is clomiphene. Another one is letrozole, which is noted in italics towards the end. Most of the textbooks I've seen only had clomiphene listed, which is why I put letrozole towards the end. And some of the textbooks didn't even have it. So if you're in nursing school, just pay attention to what your school wants you to know, because this might be all extra. The mechanism of action here is it causes growth in the ovarian follicle by stimulating the release of FSH and LH. This is meant to make the egg prime to ovulate. It's not meant to actually stimulate ovulation, even though that's the drug class. It's actually meant to prime the follicle in order for it to get to ovulation. What do we use it for? To promote ovulation. It is a little bit complicated about when exactly we give this medication. I did put these directions in here about when you take it, how often you take it, when you start taking it. I can't imagine any RN test talking about all that, but I did go ahead and throw it in here. You may also see this drug listed as a SERM, a selective estrogen receptor modulator. So you may see it there as well. Letrozole, I already mentioned. And finally, if we're talking about trying to get pregnant, we very often, the first line pharmacological treatment is going to be to give that clomiphene or letrozole, and to give it in order to stimulate that follicle so that we have a good follicle ready for conception. But then we may also use what's called HCG, which we would give an injection to the woman and we would give it very close to ovulation, and it would be based on ultrasound imaging. We would check exactly when the woman should take the injection, and at that point the OB would say, and then exactly 12, 24, 36 hours later is when you'll be actually ovulating. They'll tell you exactly, so you know when to have that unprotected sex to hopefully be able to conceive. Now, when we talk about that's all in regards to trying to become pregnant. Let's move on to someone that's already pregnant. Next, we have our tocolytics. Tocolytics are drugs that are used to delay or stop preterm labor. Preterm labor is where a woman is having steady, productive contractions when it's too early. What's considered too early? Universally, anything before 38 weeks is considered too early, but you may also hear different terms of before 36 weeks or before 32 weeks. There's definitely different definitions. I think if you say before 38 or 36 weeks, you'll hit almost all the different textbooks about what's considered preterm labor. So the different drugs that we have, again, these are all designed to stop the uterine from contracting so that baby gets to stay in mom for longer and continue growing until baby is what we consider fully developed. All this being said, I do want all of you to understand that generally speaking today in the United States, if a baby gets to an appropriate level NICU and is born in an appropriate level hospital, even at roughly 24 weeks, they already have a 90% chance of surviving. So the survival rates are extremely high for babies born today premature. So just understand that. Next, we have terbutaline, nifedipine, magnesium, and indomethacin. These are the 4 drugs that are most commonly used as a tocolytic. Again, a tocolytic is given to stop or delay contractions. I did list the mechanism of action for each of these individually because all of these are drugs that are actually used for something else. One of these is a calcium channel blocker, one's actually an electrolyte, and one's an NSAID. So we talk about all these in different places. So I just listed it really quick here. I can't imagine RN level exam getting into the exact mechanism of action of each of the different tocolytics. Next, what do we use this for? As I mentioned, to delay or prevent preterm labor. Tocolytics are limited to use up to 48 hours. Next, we have patients with preterm labor may also be treated with steroids. If we see that the baby is going to be born early and there's nothing we could do about it, we may give steroids in order to at least help the lungs inside mom, or the lungs of the baby while still inside mom, help them grow a little bit faster than they naturally would, so that when baby comes out, they're able to survive. Now we move on to the actual delivery. For this, we have oxytocin. And for oxytocin, we have we have 2 different indications of when we use it. We use it for the induction of labor and for postpartum hemorrhage. What does it do? It causes the uterine to contract. Obviously, if baby's still in there, that contraction is going to induce labor. If baby's already gone, that contraction is actually going to slow down the bleeding, because when mom gives birth and there's a lot of vaginal bleeding, when we have the uterine contract, that's basically like the uterus putting direct pressure on itself to control the postpartum hemorrhage. The onset of this drug is given via IV, and it usually works within 1 minute. It does have a very interesting black box warning that it's not to be used for the elective induction of labor. However, of course, we do use it for that every single day. Patient education, you do need to educate the patient that this is going to give them very strong, very powerful, very painful contractions, which is where an epidural or whatever mom's favorite option is to keep the pain from getting out of control. Next, we have estrogen replacement. So we're moving on from talking about contraception and conception and delivery, and we're moving on to estrogen replacement. Before we do that, I do know we didn't mention some things. We didn't mention some of the methods of contraception, such as NuvaRing or Nexplanon or some of the other options out there. I really didn't see that mentioned in any of the nursing textbooks, at least not more than just 1 or 2 sentences. So I left it off of here. But if your school wants you to know it, then make sure you study that. Next, we have estrogen replacement, and estrogen replacement is going to be starting with conjugated estrogen as the medication here. How does it work? Well, it is estrogen. It's synthetic, but it's estrogen. What do we use it for? We use it for the symptoms of menopause. We also use it for breast cancer, and does have a black box warning. 2 of them, or 3 of them, I should say. 1 is for endometrial and breast cancer, that it has a higher risk. 1 is cardiovascular disease, and 1 is dementia. It does have a whole bunch of side effects and a whole bunch of different routes. Again, I don't know that you'd have to know all that, but I did list it all over here. And obviously, this is going to be teratogenic. Moving on from female reproductive health, we're going on to male reproductive health. So we start with an androgen as the drug class, and the drug over here is testosterone. What does it do? It causes anabolic and androgenic effects. What does that mean? Anabolic is going to be the muscle growth, and androgenic is going to be developing male sex secondary characteristics such as deepening of the voice, hair on the face, etc. What do we use this for? We use it for delayed puberty. We use it for hypogonadism. We also use it for hormone replacement therapy. It does have a black box warning of hypertension and virilization in women and children. Virilization is where they develop secondary male sex characteristics. It is available in many different forms, such as IM, transdermal patches, gels, creams, buccal and pellets. You will note it's not available PO. I shouldn't say that because it is available PO, but it's rarely used PO because it doesn't work very well PO because of the first pass effect. So all of these other routes are all meant to be parenteral routes in order to not have the issue of the first pass effect destroying any PO version. Next, we have some of the signs and symptoms. Insomnia is one of them, aggressive behavior, and polycythemia. Polycythemia is an increase in red blood cells. Hopefully, you know that that can cause to a risk of clots. So again, you have to be thinking about that, especially as a nursing student. We can definitely test you on if what would be a risk with this medication. Recognize the polycythemia, you should recognize that there's an increased risk of clots. This medication does require regular monitoring of the hematocrit, probably the hemoglobin also, a PSA, the prostate-specific antigen, as well as testosterone levels. And this is a controlled substance because of its risk of abuse. Next, we're moving on to BPH. BPH is benign prostatic hyperplasia. This is more commonly known as an enlarged prostate. In terms of males, almost everyone will eventually get it. The statistics are something like 70% of men over 70, 80% of men over 80, etc., do get BPH, benign prostatic hyperplasia. Again, it is benign, but it does have some issues. So what's the issues with benign prostatic hyperplasia? The main issue is the inability to start or maintain a strong, steady flow of urine. And what ends up is the patient ends up having to go to the bathroom many, many times. They have difficulty starting and maintaining a stream, cause a big issue with nocturia if they're having to go during the night, and that's disrupting their sleep and their quality of life. So we do have the alpha blockers and the next drug class, the 5-alpha reductase inhibitors. Those are our two major drug classes that we use to treat BPH. We'll start with the first one, alpha blockers. The most common medication in this class that we use is tamsulosin. We did already cover this class if you've already watched our shock lecture where we talk about all the different alpha and beta agonists and antagonists. We talk about this there, but we'll talk about it in more detail here. And we're going to focus on BPH because some drugs in this class are actually also used for high blood pressure and some are used for both, as listed here on Bullet Point Nursing. The mechanism of action is that it blocks the alpha receptors, which blocks vasoconstriction. Plus, that's how it helps for high blood pressure. Plus, for us today with BPH, it works by relaxing the prostate. If I relax the prostate's not pushing on the pathway of the urine flow, not inhibiting that pathway of urine flow. What do we use it for? Both BPH and hypertension. I did list specifically which ones for which. The major side effects of this medication are orthostatic hypotension, which almost always goes along with reflex tachycardia, plus sexual dysfunction. Do note that when a patient develops sexual dysfunction, we treat it with the PDE5 inhibitors, which we're going to get to in a minute, but also keep in mind that PDE5 inhibitors may interact with alpha blockers, so you do have to be careful prescribing those two together. So do keep that in mind, even at the RN level, to know that potential interaction. Phentolamine is a drug in this class that's used for extravasation that certainly wouldn't be on a reproductive health test, but that is part of the alpha blockers class, so I did keep that in there. Next, we have the 5-alpha reductase inhibitors. The drug over here is finasteride. Some guidelines say that this is first line. Some guidelines say the alpha blockers are first line. I'm staying out of it. The mechanism of action for this one, for finasteride, is that it inhibits 5-alpha reductase, which converts testosterone to DHT, and DHT causes prostate growth, so it prevents prostate growth. This does take some time to work. The indication for this is BPH, obviously, plus it's also used to treat male pattern baldness. The adverse effects, just like the last one, is that it can cause sexual dysfunction. Generally, this means that the male would be unable to maintain an erection or to achieve orgasm. Next, we have the PDE5 inhibitors. These are very famously Viagra, Cialis, Levitra, more commonly known as sildenafil, or not more commonly, but more correctly known as sildenafil, tadalafil, and vardenafil. These work by increasing blood flow to the corpus cavernosum. That gets increased blood flow to the penis. What do we use this for? Obviously for erectile dysfunction. Plus, we also use this for PAH, pulmonary artery hypertension. The side effects of this medication are headache, hearing, and vision issues. Again, anytime you see hearing and vision issues, make sure you're aware that for testing purposes, you may get asked about checking their hearing or checking their vision prior to starting the medication. It can cause hypotension and it can cause priapism. Priapism is an undesired erection that lasts more than 4 hours, and that can cause permanent nerve damage to the penis. If that's the case, the patient does need to go to the emergency department, and the treatment for that is they take Levophed, which is norepinephrine, which is a vasoconstrictor, and they inject a little bit into the base of the blood vessels at the base of the penis, which it's a vasoconstrictor, so it's going to take that blood out, not literally take it out, but it's going to constrict those blood vessels so the blood flow goes away from the penis and the erection goes away. Tadalafil is also used for BPH, which we talked about just now, the benign prostatic hyperplasia. That's the only one of these that's also used for BPH, at least to my knowledge. And these medications are often used to treat the side effects of other medications. In fact, if you're ever to the point where you're doing a history on a patient who is complaining of erectile dysfunction, one of the first things we do is look at their med list and see if any of the medications are causing it. Finally, I don't know that this would be covered in a reproductive health lecture as opposed to an infectious disease lecture, but just in case, here goes. Here are some of the most common STDs and some of the medications that we use for. Chlamydia is treated with doxycycline or azithromycin. Azithromycin has okay, we'll skip that. It's probably too in-depth for this. But gonorrhea would be next. That's treated with ceftriaxone. Almost always, if a patient has chlamydia, we're going to treat them for gonorrhea and vice versa because the two most commonly go together. Syphilis is another one that's treated with penicillin G. That's just a single dose. If a patient gets an outbreak of herpes, we treat that with acyclovir. Remember, we treat the symptom with acyclovir. There is no cure for that. Trichomoniasis, which is a protozoal infection, that's treated with metronidazole. And finally, candidiasis, which is a fungal infection, is treated with fluconazole. Thank you for listening. If you have any questions, please reach out. Please subscribe to our channel and have a great day.